Welcome to Fellows Corner. Today we are going to demonstrate a case of tumor debunking. I am joined here with two of our IP fellows, Dr. Krishna and Dr. Rajendra. Coming to the case details, we have a 48-year-old female who presented with complaints of cough and breathlessness since 6 months. She had scanty hemoptysis on and off since 6 months and 2 episodes of hemoptysis recently. She was rushed to emergency room with respiratory distress. The CT which was done at an outside center showed a tumoral growth in the upper trachea, and also we can see a large carinal mass causing near total occlusion of the airway. Also in the lower cuts we could visualize another tumoral growth in the right intermediate bronchus with collapse of the right middle lobe and the right lower lobe. So now we are going to do a check bronchoscopy first. We are doing the procedure under general anesthesia and we are using the 3rd generation LMA, that is the iGel, the supraglottic device. We are using the adult bronchoscope. So here we can see that there is a tumoral ingrowth from the left lateral wall of the trachea. We will slowly pass the bronchoscope beyond to see the carinal growth. We can see that there is near total occlusion of the trachea. We will slowly slide the bronchoscope to visualize the airway further from the tumor. Suction. Come back to identify the carina. So here we can see the carina, the growth is above the carina and we can see that there is a tumoral ingrowth in the right intermediate bronchus. Causing total occlusion. Visualize the right upper lobe. Okay. We will go to the left main bronchus. Action. Vision. So we can see a lot of secretions, pent up secretions in the left main bronchus. This is usually the reason for patients to deteriorate. We will clear the airway first. Clear the left lower lobe bronchus. Okay. So the plan here will be to first snare the upper tumor. Yeah, you can come out and clean the working channel. Snare. We are using a small electrocautery snare. So he is inserting the snare outside through the working channel. So I think we can debulk the upper part of the upper tumor with iGel itself, and once that is done we can change over to rigid bronchoscopy for conduit and better control of the airway. So when we are using snare, electrocautery snare, it is very important that we keep the FiO2 less than 40. Always communicate with your anesthetist. And always keep the vision clear. So here once we are near the tumor, slowly get the guide sheath out. Yeah, slowly get the guide sheath out. And it is always very important that the operator communicates with the person who is holding the snare.
Open?
No, so you have to, just a minute, one minute. So you can try to open here or you can try to open this way. Also try to keep the snare in the center of the lumen and visualize and loop around. Get the vision clear first. Okay. Yeah, turn on to the left side. Okay, little more you can move and okay, get the little more turn and get the snare, get the guide sheet out. You can come a little behind so that you can see where the guide sheet is coming from and where the snare is opening. Little more to the left, like this. Okay, little towards the left. Slowly open and see. Communicate properly with the operator.
Opening. Open.
No. You have to get it onto the center of the airway. Just try to manipulate and try to get, you can pull the guide sheet back so that you have better vision of where the snare is opening. Pull the guide sheet back, yes. Open the snare slowly.
Open.
Okay. Under vision you have to make sure that it is loop on that side. Or you can try to loop around from below.
Vision.
Okay, clear the airway first. Clear the camera first. Yeah, come back.
Open.
One minute. Yeah, try to open here and loop around. Open slowly.
Opening. Open.
Pull the guide sheet a little back. Guide sheet a little back. Guide sheet a little back. Open little more.
Open one.
Yeah, now you loop around slowly by turning and flexing. Now you turn slowly. Very good. That side? Yes. So now what you will do is, now that the snare is around the tumor, push the guide sheet towards the base of the tumor. Little more you have to go close. Slowly close and communicate with
Close.
When you get resistance, you have to communicate with him. We are using endocut Q, and when you have the resistance, push the very near. So now you can activate the yellow switch on the pedal, and you have to slowly keep closing the snare till the tumor is cut. When you get a giveaway, you communicate with him.
FiO2 less than 40.
FiO2 is less than 40.
Cutting.
Close. Keep activating till you get a getaway. Pull the
no resistance.
Snare inside. Okay. So you have got the giveaway, right?
Yes.
Okay. The part that is snare is in the airway. Now we'll extract it using a 1.7 mm cryo probe. Slowly, be very careful when the cryo probe is coming out. Okay. Here the surface area of the probe that is touching the tumor has to be more. Press on the tumor and activate the pedal.
Activating, ma'am.
Little more you can press. You can just leave the pedal, let it thaw. Now you can press. Little bit push the probe to the tumor and then you activate. Little push the probe. See if the tumor is holding on. keep activating. Okay. Slowly under vision, get the tumor out of the airway. Okay. So the first step is done, the upper tumoral growth is removed. The next step is to debulk the carinal mass. So we will be changing to rigid bronchoscope to have a bigger conduit, and multiple instruments can be passed through the, there is a small piece left behind. Okay. So quickly once we will go and check if any remnant piece or bleed is there. Okay. Okay. Come back, we will change to the rigid bronchoscope. So the next step is to debulk the carinal tumor, which will be demonstrated by Dr. Rajendra. We are using a rigid bronchoscopic barrel. Use the telescope to get that bubble out. So the first step in rigid bronchoscopy is visualization of uvula. Visualize the uvula first.
Yes, ma'am. Uvula, ma'am.
Okay. The second landmark is the epiglottis. So once we slowly lift the epiglottis, we will visualize the vocal cords. You can use the camera to, you can push the camera to just clean the surface of the camera.
Yes, ma'am.
So once we go little more, pull the telescope.
Yes, ma'am.
Slowly move towards the vocal cords. At the vocal cords, rotate the barrel.
Yes,
so that the bevel passes between the vocal cords.
Yes, ma'am.
Advance the bronchoscope. You can change the hand to rotate the barrel and slowly advance. You have to maintain the axis always. Slowly rotate and advance the barrel. The rigid barrel should not touch the posterior wall. Advance the barrel little more. Okay, and we can now connect to the ventilator. Hold. Clean the camera. Okay. We'll use the bigger snare. Visualize and clear the secretions around the tumor. You can go beyond the tumor onto the left side. This is the right intermediate bronchus. Okay. We'll clear the working channel.
Yes, ma'am.
Suction, and we'll load the snare through the working channel. Okay, pull back. So we can pull the barrel a little back so that it doesn't come in the way of the flexion of the flexible bronchoscope. Get the sheath outside.
Yes.
Okay. Loop it from below upwards as the attachment of the tumor is onto the anterior wall.
Okay. Oh.
So try to loop from the right side of the tumor. We'll try to open from the right side.
Opening.
Okay. Opening. Oh, slowly try to loop. Pull the sheath back. I'll try to close the snare.
Close snare.
If there is any issue with the flexion, we'll pull back the rigid barrel. Try to go from the left.
Open.
Try to go from the left, little more towards the left side. Opening the snare.
Fully open.
Open fully.
Open.
Open, fully open. Pull back a little bit. Now try to loop from the left side. Flex slowly.
Yes, flexing, ma'am.
Just see if both the sheath. Yeah. Little more.
Yes, ma'am.
Okay. Resistance. I'm feeling some resistance. Activate the pedal.
Activating, ma'am.
Press. Keep pressing. Slowly closing. 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 Give away. Just come back and clean the. Okay. Have a proper vision. Have a proper vision. The tumor will occlude the airway. Take a rigid forceps. Cryoprobe. Don't ventilate, ma'am, for a minute. The tumor is moving here. Pedal. Push the probe onto the tumor. Push the probe onto the tumor. From here, you press it. Freeze. Press onto the tumor and freeze. So we need to clear the tumor fast. 1 minute. Just keep vision of it and keep pressing the pedal. Push the probe a little bit and see where the tumor is. Slowly pull back, slowly, and try to get it out through the lumen of the bronchoscope. Keep pressing. Okay. Push the probe. Okay. Connect ventilation. Back ventilation. Okay.
Open.
We can see the base of the tumor. Just visualize the carina.
Yes, ma'am.
Try to see the area from where the tumor was originating. A small piece is still left behind, a part of the tumor.
Yes, ma'am.
Okay, so we'll use the rigid bronchoscope and do mechanical coring. Clean the camera.
Don't bag.
Don't back, sir. White balance. Okay, slowly advance the rigid barrel. Keep the barrel lifted.
Yes, ma'am.
Make sure the bevel is not pressing onto the walls of the trachea. Lift and try to go a little close to the tumor and lift. Try to use the bevel to cut the tumor at the base. Lift the barrel.
Yes.
Rotate slowly. You have to make sure the axis of the. Okay, I'll show once. Ventilate. Hold it. Okay, don't bang.
Don't bag.
Flexible scope. Leave suction. Gel. Suction. Okay. Okay. Disconnect the ventilator. Leave this hand. We'll connect back the ventilator. We'll use rigid suction. Cap chain. Camera clean. We'll use the suction to remove the remaining part of the tumor.